here's what's up. Some folks out there, for various reasons I'll get to, are interchanging hydromorphone for morphine, making what was then DDMAPH with morphine, this the M, to DHAPH. Basically, these are the same molecule except for what you see in those red circles. On the left, morphine has a hydroxyl ion in that position on the benzene ring, whereas hydromorphone has a oxygen molecule. That's it, folks. They're so much like each other, but as you know, with small changes in the molecular diagram, you see sometimes large changes pharmacologically. So here's what happened. Late in 2024 and on through early in 2025 and pretty much gone now, there was a morphine, and I put it in quotes, shortage in selected pharmacies. Some pharmacies had reached their limit because we use so much morphine, such large quantities, that they had reached their annual limit and they couldn't get morphine in those pharmacies at that moment. What this created for us, oddly enough, at the Academy was kind of a natural experiment. We've had morphine ever since the DDMP2 days, way back in the late 2000s. We've always had morphine as the opiate in whatever aid and dying formula we had, with the exclusion of when people are using secobarbital alone. So morphine's always been present. We never got a chance to try anything else because once we know something is working, it's not legal or moral for us to take out something that's working and try something that we don't know if it works. The only thing we can do is watch and see what happens out in the community, collect data as we always do, and make conclusions. But here, lo and behold, somebody delivered us this natural experiment and said, you can't get morphine. Now what are you going to do? So we opened that up on the listserv, and we asked this question: what would be another opiate for some pharmacies that can't get it? What's going to be next? There's a lot of debate about that. And when we looked at cost and availability and potency, we came up with the most logical is, as you see by the similarity in the molecules, hydromorphone, also called Dilaudid as its brand name. There were some other theoretical advantages. As you know, many of your hospice patients are on pretty high doses of morphine. Few hospice patients are getting hydromorphone. Morphine is by far the most commonly used opiate for pain control. So it may well be that when we see our opiate-tolerant patients and they're mostly getting morphine, maybe switching to hydromorphone in our aid and dying concoction will be an advantage by slightly hitting the receptor differently. We don't know because we never looked at it and never really did the study. But here, lo and behold, we're given this study to do. And I was actually pretty uncomfortable because we didn't know whether hydromorphone would be a complete bust or whether it would work at all. So we calculated the equianalgesic dosage of morphine to hydromorphone, and you'll see at the bottom there, it's about 3 to 3.5 grams of hydromorphone. Again, that's equianalgesic. We're not looking for analgesia in our patients. We're looking for respiratory suppression. And we don't know how much those things correspond. All we know is that we have these equianalgesia tables. All right, so here's what happened. I'm going to deviate for just a second to bring you back to what most of you remember as your favorite topic of all time, statistics, and just briefly show you how the Academy methodology is used when we're looking at different aid and dying formulas, how this has worked over the years. If you look here at this top diagram, you're going to see that there's a whole bunch of dots on this XY axis within that are clustered fairly tightly. And when they're clustered fairly tightly and you calculate a mean, which means you're doing that calculated average, you add everything up and you divide it by the number of points you have, that's when you have a calculated mean. And then the median, which means that that's the line where there's the same number of reports on one side as there are on the other side. It's just looking for that mid-range between all of the data points. And if you have a tight cluster like this, the median and the mean pretty much fall into the same general area. They're very, very tight. But that's not what aid and dying patients look like. They look like this bottom graph. On the bottom graph, what you'll see is that we have a great clustering of 80 to 90% of our patients cluster in this range of time here. But then we have these green, nasty outliers that go way out to the side, some of them quite far out. And what they are doing, there's not enough of these to change the median very much at all. So the median pretty much stays where it is, but the mean, because you're having all these high numbers calculated in, the mean changes. So why do I bring this up? It's as follows. Here's our data so far on hydromorphone versus morphine, and just remember that quick lesson on medians versus means. There's a big problem with this when I first show it to you, and you can see it right at the top. Morphine, we have about 1,946 reports into the Academy's data collecting system, which I hope you all participate in by reporting your cases. Hydromorphone, on the other hand, on the left, 25 cases. So there is really, as of yet, no comparison, but let's look at what this data is showing. First of all, if you look at morphine, you can see just what I pointed out before. Given the number of outliers that we have that are so long, if you look at the 3 longest deaths, by the way, many of these were accidents or anything else. I'm showing you the worst case scenarios here. We have a 41-hour death, a 30-hour death, and a 25 in the longest deaths. That really pulls out those outliers and moves the mean, but again, the median stays kind of the same. So that's what you see with morphine. Now let's look at hydromorphone at an N of 25. Not a whole lot of cases, but look at how close the mean and the median are, because these deaths really, really cluster very nicely, with the longest death 7.8 hours, then after that 1.5 and 1.3. So you can see that our goal, if what we're looking at, and let me go back up here for a second. When you look at this graph, at this cluster, right, that's what we're going for. We're not going to improve these deaths here. No matter how much we make the pharmacology work better, those deaths are just fine. They're already good deaths. It's these long outliers down here that when we improve pharmacology, we want to pull in those outliers and bring them into that cluster. So the goal of what we're trying to do is to change the mean while having the median stay close to it. And that means that we're pulling in outliers. When you see that you have a far distance between mean and median, it means there are prolonged outliers. When you see these two coming close together, it means that the outliers are much less. Another way to look at this is your more familiar graph that you may have seen from the Academy over time. If you look at hydromorphone down here, this big blue area are all deaths under 2 hours, and it's 96% of all of those 25 deaths are under 2 hours, and 4% go into the 5 to 10 hour range, whereas you look at this complicated death with our 1946 number N of morphine, you can see that about 79%, we'll call it 80%, are under 2 hours, but then we have a wide spread, 2 to 5 hours, 13%, 5 to 10 hours, 5%, about 1.5% go out 10 to 20 hours, and you have 0.4% above 20 hours. Okay? So if you want to be naive and not consider the fact that there's no statistical reality to an N of 25, you might say that, hey, look at that. Hydromorphone looks pretty good compared to morphine. And of course, that's not true. We don't have enough numbers yet. Why am I showing you this? I'll call this a proof of concept. We at least have proven that hydromorphone works. My initial fear was, what if it doesn't work very well at all? And that's just not the case. I think in 25 cases, given these results, we can pretty much say that, this stuff works. Whether it's as good as morphine or equal to or worse, I don't know. But we know that it works, and it's not a major danger to try it. So let's go down here. And what are the advantages of hydromorphone? Well, I have the slightest idea. And the Academy has no position about that. But if you, as an individual clinician, want to look at this data and say, you know what? I'm an individual clinician. I'm not experimenting. I'm making individual decisions about my patients. And what you're seeing from this very preliminary data, I'm going to keep trying hydromorphone and see how it feels to me and how it works with my patients. And I would say even especially in your high morphine tolerant patients, this may be of some benefit, or it may not. I don't know. But you can make individual decisions for your patients based on whatever data that you see and how you interpret it. Should you consider that you want to continue to use hydromorphone for all or some of your patients, send us data so that we can get to the point where we understand better and we can report back to you. That's what we do best. We collect data from you and we feed back to you what's going on, and that makes you make better and more informed decisions. So the advantages of hydromorphone, if you want to do it, Nobody knows. Disadvantages. It is more expensive. There's an increased cost estimate. Roughly, I talked to the pharmacists about this at their meeting. Roughly, they think between $200 and $400. It's cheaper if the pharmacist knows that you'll be using hydromorphone, because if they get more of it at one batch, it's less expensive. And one other disadvantage is not all pharmacists can access it, and some pharmacists don't want to bother. The Academy's recommendation at this time: none. We don't have anything to tell you. It's too soon. We don't have good data. If we get more data, we will learn more, and it's up to each individual clinician to look at the present data, decide what to do for your patients, and then report your data to us, and we'll keep track of things on a larger scale until we can bring this N up from 25 to maybe 250 or maybe 1,250. I don't know. We'll look at it, we'll work through the statistics, and then report back to you about whether hydromorphone may be, just might be, better than morphine, in which case we would then make a recommendation for a change. Okay, now that I've edited this video, there are two other points to make for those contemplating using hydromorphone for all or some of your patients. First, talk with your pharmacist. They'll let you know if they can get the hydromorphone and roughly what it will cost your patients to use it instead of morphine in the formula. Then, talk with your patients. They should know that hydromorphone may or may not improve their result, but very initial data is promising. You might also explain if there are any individual factors, like high morphine tolerance, that make you think hydromorphone may be a better option. And it'll cost a bit more. As always, provide information for informed consent. Okay, that's it. Bye.